We'll get things underway. Thanks very much to everyone for joining us. I think there's still a few trickling in, but we've got a bit to cover, so we will get going. Yeah, and look, as I think everyone probably gathers, we're here to talk about the findings from the 7th Australian Healthcare Index, which came out a couple of weeks ago, and discuss some of the findings from that and potentially what we can do about it as well. So, for those of you who don't know me, my name is Dan Stinton. I'm the CEO of Health Engine. I hope most of you know of Health Engine, if not all of you know about Health Engine, but just in case you don't, we're Australia's largest provider healthcare platform. We've got about 10,000 practices that are listed on Health Engine and almost 30,000 practitioners. And look, what I've witnessed over my time at Health Engine is that the industry and the practices and practitioners do a pretty good job of making their voices heard in Canberra and everywhere else, as they should. I mean, it's a very important industry. I would argue the most important industry in the country. But it is very rare that we actually hear from the patients that are in the system as well. And so we have partnered with Patients Australia some years ago for this report in order to be able to shine a light on what patients are feeling about their interaction with the healthcare system and how it's working for them. Today, I'm going to be joined by Lisa Robbins, who's the CEO of Patients Australia, and Dr. Nick Coatsworth, who's a medical advisor and public health expert. I'll stop sharing my screen for a second and allow you both to introduce yourselves. So, Lisa, perhaps first to you.
Hi, everyone. As Dan mentioned, Lisa Robbins, CEO of Patients Australia, formerly Australian Patients Association. We're really delighted to be part of this webinar again, year on year. It's wonderful to be able to bring patient voice out to represent what the key issues are for patients. And this year, we'll be introducing a few patient vignettes as well, as we had patients share stories. So really delighted to be participating.
Yeah, thanks as well, Dan. Likewise, it's just such a great partnership between Health Engine and Patients Australia. My name's Nick Coatsworth. I'm a respiratory and infectious disease physician. Even though we've got a white background, I am actually at the hospital today on shift. There we go. I can bring my stethoscope into view there at the acute medical unit at Canberra Health Services, where I'm seeing patients even this morning that have experienced some of the issues that we're going to be talking about. The index is I think, one of the really important pieces of patient voice and narrative, I think, and consistent narrative about the Australian healthcare system. And having been part of it for the past 3 years, really looking forward to talking about some of the data that we've got today.
Great, thank you, Nick. All right, so let me just give you a little bit more background to the report itself. So bear with me just as I pull up the slide one more time. So this is, I guess, the mechanics that goes into the report. So as we mentioned, this is the 7th Australian Healthcare Index report. We started doing this back at sort of the peak of COVID, and initially we were doing it every 6 months. Obviously, the healthcare industry was of the utmost importance and highest priority in Australia at the time. We've since moved it to annual, so we can get a better sense of how consumers are feeling about the healthcare industry over time. And now we think it provides, as Dr. Nick and Lisa have said, it provides a pretty good pulse check, temperature check, excuse the obvious pun, about how Australians are feeling about our industry. So this time around, we surveyed over 8,000 participants. That sample of 8,000 Australians, or just over, was weighted to be representative of the Australian population. One caveat to that, though, I should mention, is that only adults were surveyed, so for obvious reasons. So we don't have a huge representation of children in the system, but obviously their parents are pretty well represented in the results that we're about to discuss. So what we are about to discuss is, I guess, the key findings. So I'm not going to go into detail here, but there's probably 6 in total. I mean, there's many insights, but probably 6 that we're going to be focusing on today. And look, the first one, a pretty consistent theme: patients are delaying care due to rising costs. There's a bunch of reasons for that we'll go into. This is a newer insight that is come about in this report, and that's younger Australians and women in particular are being hardest hit by those cost of living pressures on their healthcare, and we're going to unpack why in a second. And then, similar theme: medicine affordability is getting harder. People are skipping or delaying their purchasing their essential medicines in order to make ends meet. Unsurprisingly, bulk billing is still very, very important for Australian patients, and we'll be discussing why and what's happening there in a moment. And look, on a slightly positive note, trust does remain in the system. Like, I think Australians do recognise that we have a pretty good healthcare system, but obviously we don't want to rest on our laurels. There's a lot that we still need to do. So I'll start with I just the overall rating, if you like, of how Australians are scoring the healthcare system, and they've given it a 7.2 out of 10, and that is a slight uptick, I should say, on where it's been for the last couple of years. And it is worth acknowledging as well that on a global basis, this is a pretty good score, right? Australians recognise that we've got one of the best healthcare systems in the world, one of the best funded relative to the size of our population, and relatively fair, but it is getting less fair, and I think that's what we're here to talk about. And there is some real pressures that are building that if we don't address, we're going to end up in real trouble. So we'll unpack why that is from now, really. So Lisa, I might go to you. This is, I guess, the number one finding, or the most obvious finding from the report, and that is that cost of living pressures are really impacting on Australian patients. So there's some of the stats there. Perhaps you want to talk about some of those, but I'll hand the floor to you.
Yeah, the stats are very revealing. I mean, when you look at the rate of people who are struggling with out-of-pocket costs and the fact that it's across the board in healthcare, we're not talking just about out-of-pocket costs to see specialists. It's not just in primary care. It's really every element of healthcare. And it's something that is really brought to life in some of the stories that we collected this year. So alongside the quantitative data, we asked patients, can you share your story with us? And it was as broad and open as that. And what we really heard is the anger about the impact that this is having. So, say, for instance, I've got one example of a patient mum, and in her words, I have to pay $780 for my 2-year-old to see a pediatric cardiologist. Plus, I pay $400 for his pediatrician. I'm grateful that GPs for children are bulk billed, but these costs are outrageous. And it's that word outrageous that really shows the heat that's in it for people. And I think that's something that we really need to be talking about, and not just talking about the heat that's in it, but what are we going to do about it?
Yeah, thanks, Lisa. So yeah, I mean, it's pretty concerning, isn't it? I mean, this is a pretty consistent theme. People are unable to afford care or delaying a visit to their GP, often skipping a dental appointment and the like, just to make ends meet. It was starting to be revealed a couple of reports ago, and it's got consistently worse over the last couple of years that we've been doing this report. It's also impacting on people in a disproportionate way. So I'll just pull up this next slide here. Bear with me. But this is basically emphasising that, or highlighting, if you like, that younger Australians in particular are disproportionately impacted by this. So, Nick, you're probably seeing this, or no doubt seeing this, where in your practice. Do you want to give us some insights? You might be on mute there, Nick.
God, I can't believe it. How did I fall for that? I just wanted to mute myself because I am in the middle of a functioning hospital at the moment. Didn't want to interrupt the webinar. Look, I think the key here on that slide, Dan, is that people are changing their healthcare decisions due to cost. And this is a very important section of the Australian Healthcare Index, where we asked people what was changing, and you can see some of the things that people have been doing. So changing a healthcare decision might mean delaying. Changing a healthcare decision might be foregoing. And really, an element of it is also how you pay for it. Why might younger Australians be under strain here? Well, there's a couple of reasons, but I think one of the most obvious ones is when we look at what government is doing to support free healthcare, it occurs in the under 18s and the over 65s by and large. And you can see that in the way that the bulk billing incentive schemes have been enhanced over 2 consecutive budgets under the current government in 2022 and this year in 2025. There's not much in primary care that's left if you're an 18 to 34-year-old who just needs to see their GP. The likelihood of you getting bulk billed is comparatively very small against children or over 65s. What implications might that have? Well, when we're trying to engage people in their healthcare, get them a consistent GP from a young age, particularly not just 18 to 34, but I'm now thinking 35 to sort of 60, when that key time in preventive medicine when you actually have a chance to change the trajectory of your healthcare. Uh, Actually loading up costs that are disincentivizing access to primary care is a major issue. We'll talk about why, what we can do about that later on in the webinar. But I think just that point is important. That's the primary care side of things. The other side is, well, what happens when you get into specialist care for young Australians with complex needs? Now, I've had patients in this hospital, not many, but I remember the stories clearly, who were on 4 different cardiac medications and came in with an exacerbation of their heart failure because they were a tradie and they were unable to afford their medications and they hadn't hit their safety net cap yet. So medicine's affordability a real issue. I couldn't believe that stat that Lisa just gave, the mother who's paying $780 to see a pediatric cardiologist. I'm not going to comment on what my colleagues are worth or what they might think they're worth, but I think I will comment on that's sort of the amount of money you might pay to see a top barrister in Australia. And one of the big challenges in Australian healthcare is actually you don't know when you're accessing specialist care in Australia whether you've got the best or not. That's a really interesting thing. You follow a referral pathway for your GP and you assume that everyone's at the same standard, and yet you're really paying top dollar no matter where you are in the country. So very concerning findings there, Dan. Very last one on that slide, right down the bottom, you would have seen that some people are accessing their super to pay for healthcare. Now, this tends to happen when you've got a very large out-of-pocket cost ahead of you, generally associated with a procedure. Not recommended by the College of Surgeons. And actually, if your surgeon is telling you that accessing your super is an option, that's actually a discouraged practice, by the way, amongst Australian College of Surgeons and other proceduralists. So we really don't want that. We can talk a little bit. I've got an interesting idea about how one might structure a system where you do have something like a healthcare super that is your own money to spend, but we're not there at the moment, and really we shouldn't have a system where people are diving into their retirement incomes when they're in a younger age.
Well, there's sort of 2 impacts on this too, isn't there? Or 2 consequences of this. I mean, number one, obviously, that's not what superannuation was established for. Was to pay for your healthcare. It was established to pay for your retirement. And so, if younger Australians are being forced to do this, that is going to have a disproportionate effect on them later in life.
Yeah.
But also, I mean, Nick, this is a question for you. I assume it holds, but if people are delaying care at a younger stage of their life, I mean, obviously the consequence of that means that in a lot of circumstances, their illness is going to get worse, right? So isn't that going to result in more pressure on the healthcare system?
Yeah, I think that's the general concern that we hear voiced more and more in the Australian system, that if these delays, which survey after survey is demonstrating, can only take you further down the stream on your chronic disease journey, when we want to, as a healthcare profession and indeed a health system, tackle the problems as far upstream as possible, which means, and this is really when our general practice colleagues are talking about reports that say strong health systems and healthier countries have better primary care systems. What they mean is that we are tackling problems and diagnosing them: hypertension, diabetes, early onset renal failure, all of the things that we know are going to hurt people if they're unchecked. We're diagnosing those and attending to them as far upstream as possible. If someone's got a choice between paying anywhere between 40 and $100 to go and have that discussion and other cost pressures in their lives, they're turning away from making that decision for their healthcare, and that's a major problem.
I think while we're on
Like,
the topic too, I'd also mention Afterpay, because Afterpay was pretty thematic in the patient stories. So if you're talking about the impacts, I was reading things like, I used Afterpay to cover the cost of my medical appointments, and as a result, I'm not paying for groceries, or I'm paying less for groceries. One of the patients even mentioned that the use of Afterpay to cover the cost of care meant that they were reducing their spend on medication for their children. And
Mm.
if you're looking at reduced spend on medication for their children, that means that that child's probably going without some of the medications that they're in need of, or they're going on reduced doses.
Yeah, I mean the opportunity cost of this is appalling, right? And you know Australians should not be putting their healthcare on credit. I mean clearly it's not a sustainable circumstance for us, and it's going to result in bigger problems down the track. More good news. We'll move on to the next key finding from the report, and that is the disproportionate impact of cost of living pressures that are on women in particular. Lisa, I'll throw back to you. What's going on here?
I mean, we know that there's income disparities for women. And so, in terms of the cost of care, people are talking about what I would call excessive costs sometimes. So, huge out of pockets for accessing specialists, but they're even talking about challenges with out of pockets to see GPs. And then when it comes to something like elective surgery, it's even harder. Interestingly, when you read the stories from women, they didn't tend to focus on the income side of it, but they did focus really heavily on the fact that uh, they have this sense of feeling unseen and unheard in the medical system. It came through as anger about lack of recognition for treatments that they might need. They talked about conditions like endometriosis and feeling lost in the system. So that sense of loss, you're talking about repeated attempts to have conditions explored, get assessments, they're going in over and over again. So it's not just a struggle with the cost of one consult. They're talking about repeated consults, trying to get treatment for their particular presentation. Really, really strong language used. Sometimes language like gaslighting, like you can just hear how angry they are, how unseen they sometimes feel. And I'm so glad to see that issues like medical misogyny are on the agenda now, that this is part of national discourse, and that we're starting to look at what solutions might be for this inequity that's happening in our system.
Yeah, I mean, there's a number of impacts really on women. None of them are good, right? Like you've touched on a few there, where you know the women's healthcare in general has not just received the attention of men historically. Now, thankfully, that is starting to change, and it has been changing pretty rapidly. But there's still some lagging impacts of that. Number two, as you touched on, you know, women typically earn less than men, and again, that is slowly improving, but not fast enough, and therefore the impact of cost of living pressures on women is disproportionate. And also women in general, and obviously as a general statement, have more complex health needs. So we're in a circumstance where women are, you know, when there's a cost of living squeeze on, as there clearly is in Australia, it's always going to be the case that women are going to be disproportionately affected, as well as young people, as we mentioned before. Okay.
I think there's just something there, Dan, which is the we describe it as the sandwich generation, and it's not a term I really ascribe to, because I think the fact is we're getting older. We're going to have caring duties for both our kids and our older generations, and I think we just have to accept that and not put a negative term on it. But the consequence of it is that you get this double whammy. Of course, you're going to prioritize the care of your elderly relative, your child. You're going to access care for them. In fact, accessing care from them, as we've already discussed, is often bulk billed in the primary care setting. But actually looking after yourself as a working age Australian is becoming increasingly difficult under Australia's healthcare system, which outside an emergency department, we need to start using words, and Patients Australia has, like non-universal. I mean, honest conversations mean talking about what universality actually means. Does just turning up to your emergency department and getting free healthcare, is that our standard of universal now?
Mm,
Because if it is, that's not exactly what's being sold to us.
mm.
And it's certainly not what we're finding from the survey. And I do think that it is really affecting that working generation, caring up, caring down, not caring for yourself, because it's starting to cost a lot of money.
Mm. I mean, just on that point, I mean, we haven't gone into the specifics of this for today's webinar, but it is worth touching on one of the findings, which is, you know, that the proportion of people that are visiting the emergency department as a way of accessing free care is on the rise, right? And a lot of those people are reporting that they acknowledge that they could have gone and seen their GP about their condition, but couldn't afford to do so. So, yeah, to your point, I don't think universal healthcare means that a proportion of the population are having to go to the ED in order to be able to receive the care they need. That's clearly not what we want, and it obviously has other impacts on those that actually do need emergency care, right? So it's not a very not a positive story. There is some positivity coming later on, but we'll get to that in a second. More concerns though. So I'm going to talk about medicines affordability now, and I'll probably throw back to you again for this one, Nick. But medicine affordability has been a concern that's been picked up in the report for a number of years, and it seems to be accelerating with this latest one. So, what's going on here, Nick? Are you seeing medicine affordability being a problem for your patients?
Yes, I do. Although I think, of all the things government's done in recent times, we do have to acknowledge the reduction in prescription cost. I mean, by and large, you're still getting your meds as a concession card holder, I think, and as a pensioner. Concessional costs about four bucks for a script. And I mean, we do have to look at the positive side of these things, Dan. As you quite rightly say, we can't sort of be overly negative about a system that gets a net promoter score of 7.2. And we do have to acknowledge that if I go and get my blood pressure medications with a Medicare card, it's costing me 25 bucks. With a concession card, it's going to cost me 4 bucks. However, I think there is a couple of subgroups of patients. There was the young cardiology patient that I mentioned that was on complex multiple medications, where that 25 bucks actually ends up being 125 because they're on 5 different ones. And then there's a subgroup of patients, and this is a slightly different topic, but it's important to mention, whose medications haven't made it to the PBS. That's a whole other debate that we haven't sort of discussed here. But that's something that we can sort of put into the medicines affordability sort of basket. My overall impression is this is an important thing for the AHI to track. It's Obviously, if you're diagnosed with a condition, you can't afford the medicines, your condition's going to deteriorate. The cost of medications in Australia, I think, is comparatively low and is affordable, but we need to sort of track that over time.
And Lisa, are you seeing anything like this? Have you got any stories of people with having to skip medication or the like from Patients Australia?
Yeah, I do. I mean, even though we're talking about it being relatively affordable, which it is, you're still seeing people who are caught in between. So, one patient story I can share, for instance, a gentleman was living with diabetes, also on disability support pension, single dad, 2 children at home, cost of living impact. He was self-titrating his own insulin, so reducing it without the doctor's awareness at the time, in order to be able to afford his medication. So, we've got this general sense that it's okay, but it's not. Another story that we collected through the AHI, it's one individual who is using Afterpay for their medications, and they really wanted to make a point of that. In their own words, they said something needs to be done about the cost of living going up, but so are the costs for medications for me and GP visits. It's hard enough without having to compromise in my financial situation. So it looks good, but it's not good enough still.
Mm. Yeah, pretty harrowing stories, right? I mean, I think, Nick, you're right to point out that the PBS is a fantastic scheme for Australians, and many countries around the world don't have an equivalent like this, and so we're pretty fortunate to have it. But yeah, as the number of people that are slipping through the cracks with that and still having to manage their medications because of cost of living, and defer or delay it, or sometimes not take it at all, is rising. And if that keeps happening, obviously we're going to have the downstream consequences of that, as we've touched on as well. So. All right, moving on. Bulk billing. So, Nick, I'll throw back to you for this one. But it is worth noting that 49% of Australians are visiting GPs less often due to costs. So that's actually been a pretty consistent score over this survey and the last survey that we did a year ago. But bulk billing is still one of the top issues for Australians when it comes to accessing the healthcare system and the availability of bulk billing. So, what's your experience with this, Nick?
Well, I mean, the experience is the same as most Australians. I see the costs myself. I also see the value of when things are bulk billed. I was very fortunate to have a family member bulk billed the other day. And I think it's a good way to open this conversation, because this was a 40-minute consultation, complex consultation with an older Australian. And the I looked up the MBS item for it, and it was bulk billed at $125. Now, in contrast to previous comments about subspecialty medicine and how much it was costing to see those subspecialists in pediatric conditions, let's honestly consider whether we think $125 is a sufficient rebate for a skilled GP to see an elderly Australian for 40 minutes. And if we simply take that statement and consider what that cost is relative to other costs that we have outside our healthcare, utilities, maintenance, other consumer products that we might want to buy, that $125 seems low. And indeed it is low, because it needs to go and fund the practice. It needs to fund the rent. It needs to fund the equipment. It needs to fund the nurses. And this is where I have a lot of concern from primary care colleagues. When we talk about increasing costs, there genuinely are hyperinflation of costs related to delivering the care, not just the money that the doctor's taking away, but the money that costs to run the practice. So then the next question, and this is where it starts getting really difficult, because our surveys, the AHI has consistently shown how much Australians value bulk billing. We've just had an election campaign run entirely on bulk billing, and some might even say won substantively on bulk billing in Medicare. And yet we know that the bulk billing rate for that complex consultation for an older Australian is insufficient for a general practitioner to run that practice. So there's a big disconnect between what government promises, what Australians want, and what is actually able to be delivered by general practice, and that that might have to change. There's only two things that can change. Either that rebate keeps going up, and I know that the RACGP and the AMA have asked for that in various sort of ways, or we might need to look at different funding systems entirely, where it's not about turning up to your GP and expecting to get bulk billed. There will be some things that are for free, and there will be some things that you might need to pay for, and that if you're a certain type of patient, your GP gets $2,000 a year to look after you and has to make the best with that. That's called a capitated model. I'm raising these things not going into much detail on them, but simply to make the point that Australian primary care has a choice. When I say that, this is all of us. We have a choice of whether we want to keep this so-called idea of bulk billing and fee for service, or is that really a thing of the past, which most people in this sector who have a strong view of it will say that it is an inadequate funding model for complex chronic disease. Until we address that question, I think we're going to continue to see increasing gaps in primary care as general practitioners simply have to cover the costs and of their practice, and also their own income, because we can't pretend that their own income is not a part of the cost there. Of course it is, but I do worry that there's no sign that gap is getting any smaller, and I'm really interested in what happens in only 16 days, Dan. 16 days on November the 1st, the government's bulk billing incentives for this budget tranche come in, and we are supposed to see the move towards 9 out of 10 Australians being bulk billed by 2030. That's what the budget was supposed to do. So I think people watching this webinar, I'd be very interested that they have a look at their own experience within their families after November 1st and see if that's actually changed.
Yeah, I mean, you've touched on a couple of really good points there, right? So, and this is something which I don't think gets talked about enough in the debate, outside of the industry, at least. In the industry, it gets talked about a lot, but it is very hard for a doctor to make ends meet too with the amount of funding that's going into bulk billing, right? So it's very difficult. There's a reason why the GPs in particular around the country have been reducing the availability of bulk billing over time. But as you've touched on, Nick, like there is more funding coming, and hopefully that will start to make a difference. Because as I said, as we started talking about this topic, it is consistently rated one of the top issues that Australians care about when it comes to accessing healthcare. Lisa, you must have some stories about this from Patients Australia. Like, what are your insights?
Um, we get lots and lots. So commonly you see the out-of-pocket costs sitting around $50 probably for primary care access, and you see more significant out-of-pocket costs for specialists. But people are dependent on primary care in terms of frequency. They're going a lot. So whilst a $50 gap might be smaller, it adds up if you're one of the people that needs to go on a regular basis. And we're definitely getting stories where they're talking about on multiple occasions postponing or cancelling their regular GP visits. And if you're thinking about the GP as the gateway and access to all other resources in healthcare, you're going without care altogether. Something that might have been preventable is going to have downstream impacts, and that's definitely what they're sharing. I think it's quite heartbreaking. They're talking about things like our healthcare system being on the brink of collapse. That's quote unquote one of the patients from the AHI survey. There's just this sense of doom and gloom from a lot of patients, and I hope that the incentives that are being put in place are going to make changes for patients. That I would like to see universal access to healthcare. But I'm concerned that that might not be what plays out, and that we need to do more. I think it's really important that we think of healthcare as an investment. If you don't have your health, you don't have anything. And we want a productive nation. We want people engaged. We want the carers of people out there being able to do what they do best. And it starts with investment in primary care, I think.
Yeah, just
Yeah.
I
Go
just
ahead, Nick.
think we need to be careful. Not careful. We need to know what we're asking for there, because
Mm.
that's a very common refrain. And I asked the question what universal care was, and we want it, and we want bulk billing. And I just gave an example of how the Medicare rebate for a 40-minute consultation is probably half what a reasonable person, if they sat down and considered what their other sort of costs are, it's half what it needs to be. So, are we prepared to fund a doubling of the MBS? Question. It's an open question. I'm not in Treasury. I'm not going to answer it. I'm in Canberra. Maybe I could talk to them about it. But I think I know what they'd say. Or are we going to? And I notice in the Q&A, Claire Jacker, thank you for your comments. I got that wrong on the concessional. I'll have to look that up, but Claire's looked it up for me. Concessional PBS $7.70. I said $4. That sounds like a John Hewson moment with not getting the price of bread right. So my apologies for that. But Claire also talked about financial supports and structures for people with chronic disease, and that's what I'm talking about when I'm saying, you can take the bulk billing system and you can double the MBS, and it's going to cost the Treasury $60 billion instead of $30 billion. I'll need to check my figure on that as well. Or we can restructure the way we fund things, and particularly target it to the people who need it most. And there's I'm going to address it later, but Les Miggles has also spoken about the Singaporean CPF account and the MediSave account, and he's beaten me to it. We'll talk about that on the last slide, because I think that's a useful idea as well.
Yeah, I mean, it's easy to say, look, more funding solves everything, but also it matters where the funding goes, right? So, and obviously funding is not open-ended. So, but anyway, there is some more targeted funding on where the more acute problems, as this report is identifying, is certainly something that should be considered. All right, we're last slide. We're going to finish with some positivity, actually. Well, at least not universally positive, but some positivity anyway. So. This one here, trust in healthcare is strong. So, as I said at the start of this webinar, Australians on the whole have rated the healthcare system 7.2 out of 10, a very, very high score. Now, it's not universally good. So private health insurance is something which Australians are increasingly seeing as a bad deal and not something that they can justify. We haven't seen a huge volume or proportion of Australians shifting out of private health insurance yet, but I think that this is a bit of a canary in the coal mine if we don't start to address some of the problems there, which we'll touch on. But on a more positive note, the NPS, that the Net Promoter Score for the people that are actually delivering the care in Australia is very high, right? So GPs and dentists, 34 and 35, pharmacists tracking up a lot this time at 44, perhaps a reflection of the increased scope of care that they're providing. But, on the whole, when people have an experience with their primary carer, they have a good experience and they rate it really strongly. And so that is something I think that we need to celebrate. Primary care is so important to deal with some of these issues before they become more serious healthcare problems down the track, and not only make it worse for the individuals that are going through that, but also end up costing the healthcare system more. And so the fact that Australians really rate their primary carers well, their GPs, their dentists and the like, really strongly, suggests that we've got a fighting chance. But Lisa, I might throw to you first on this. What's any good news to share here?
Well, there is the pharmacist. So we read multiple stories about access to care, for example, through pharmacists. People are absolutely delighted with things like being able to get your vaccination at your local pharmacist. It's just that rapid access, but also they spoke really highly of the expertise of their pharmacists. And really, that's across the board. People rate their healthcare providers. There's a lot of respect for people who are providing healthcare to Australians, and that's really good to see. I think when it comes to private insurers too, the challenge is the out-of-pocket costs that people are facing. So we saw story after story again of the weight of the out-of-pocket costs and people feeling confused. So, lifetime gold cover, I'm 66 years old. Why am I paying out-of-pocket costs that are in the thousands? And that's where that distress is coming through. But when they're expressing their distress, it's not directly at the private insurers. It's often about just feeling like they're caught in between. They're paying out-of-pocket costs. They're paying already the Medicare levy. I'm paying for this. I'm paying for that. Why do I still have such high out-of-pocket costs? And we know we're in a cost of living crisis. When you're in a cost of living crisis, you're looking at what discretionary spending can I cut? And unfortunately, some people are starting to see private health insurance potentially as an option, but it's because they're under such strain financially. And it's really distressing seeing that, because I think we need a healthy private system and we need a healthy public system.
Mm. I mean, the outcome of that, right, is we're going to see even more pressure coming onto the public health system if people opt out of private health, and that could exacerbate the problems further. But Nick, what about you? Any reflections on how Australians are feeling about the care they're receiving?
Yeah, well, you can just picking up on that last comment, Dan. It doesn't necessarily have to even mean that you're opting out of your private health insurance. Depending on your income, people will choose to have private health insurance because the tax penalties of paying the extra Medicare levy surcharge force them into holding products. And oftentimes, if you do that, for tax reasons, then you're buying the lower tier product just so you get the sort of tax benefit. But you see the effect of that in a jurisdiction like Canberra, where we have some of the highest out-of-pocket costs in Australia for procedures. You can go up the road to Sydney, up the Hume Highway, and get a couple of $1,000 discount on your knee or your joint replacement. You can get a cataract done at half price. And I'm not talking about the outer suburbs of Sydney. I'm talking about compared to practices in Mossman, one of the richest suburbs in Sydney. It's still half price compared to Canberra. So you then get a situation in Canberra where you've got something like 320,000 people who are covered by private health insurance, one of the highest coverage rates in the country, but they don't use it. So we're not actually seeing a decrease in the number of people insured, but if people aren't using it, then they're getting onto public system wait lists anyway, and there's a burden created there. So that's the first thing that it's almost unseen. The way you do see it is you're sort of shrugging your shoulders, thinking, "Why are my wait lists so high when people have got private health insurance?" Well, because they know from their mates who just had a $3,000 or $4,000 out of pocket for a hip that that's what they're going to get, and they don't want to use it. So, I just want to make that clear that it's not necessarily the first thing we see is not going to be a reduction in private health insurance numbers, but that coverage, but that can't be far away, because what we're seeing in the Australian Healthcare Index is a real dissatisfaction. It's not just with the insurers, of course, although they bear the brunt of it because they're providing the product. It's the whole system. It's the money that you have to pay for the insurance, and then the out of pocket you have to pay to your surgeon and your anaesthetists. And that's a real concern.
You raise a good point there, Nick, right? So this is something which doesn't get talked about in the Australian conversation very often, right? Because on the whole, the proportion of Australians that are holding private health insurance is staying relatively stable. But if more and more people are doing what you've suggested, which is downgrading the quality of their private health insurance just to get the tax benefit from it, then it's still creating problems which are less obvious, but obviously creating more problems on the healthcare system overall.
Yeah.
Nick, is there anything? What about the positive scores that some of the primary carers are receiving, including people like yourself?
Well, I'm not sure. I just wanted to wrap up that combo on
Sure.
private insurance, because we did speak about solutions before. Now, if you've got a high out-of-pocket cost, and we want as a patient, and we want to try and reduce that on aggregate, there's only two things that can happen. Either the Medicare benefit plus what the insurer is paying has to come up, and the cost that the practitioner is charging has to come down. And both things have to happen to make private healthcare more affordable.
Mm.
The way you do that is really important, because although there has been some suggestion that medical practitioners have their costs capped in some way, I think that is an impractical solution that's unlikely to ever come into practice for a lot of reasons. But let's just say that the profession wouldn't cop it, because they probably wouldn't. So the next best thing you can do is have utter and full transparency of medical fees, and that's what Patients Australia has been calling for. Unless it's an emergency, you must have. This is not a guideline. Of course, the surgeons and the anaesthetists and the AMA, they all have guidelines about this kind of stuff, but we actually need to mandate cost disclosures with a sufficient amount of time that a patient can then go looking or ask their GP for alternatives. Medical Cost Finder alone won't be enough to achieve this, but it's a step there. And then there should be no fee levied on an Australian seeking private healthcare that is invisible to the government. And at the moment there's administrative fees and all sorts of things that the government can't see. And the patient thinks that the government can see it, or they think that it's normal, and it's not normal. And if you can't, as a government, see how much your patient is genuinely being charged in a private system, when you're trying to run a mixed public-private system, then you can't run that system. You can't deliver. You can't deliver policy. So utter transparency to try and bring the top bit down, which is the specialist fees. But at the same time, and some of our insurance partners will be listening to this webinar, the amount that's being rebated to doctors needs to come up, because only those two things will decrease out-of-pocket costs.
Mm. It's interesting. Transparency is a good step in the right direction in a lot of circumstances. And even we see this on Health Engine, by the way. So there is a growing trend of practices and practitioners actually making their fees available to consumers to consider when they are making an appointment. So more transparency obviously helps for those that are having to make ends meet and struggling to do so. Obviously, in the more complex areas, as you've just described there, Nick, but also right down at the primary care level too. Lisa, anything to add on this point?
No, we've touched on the things that patients talk about. Definitely, they did put some of their solutions in. One of them did include capping doctors' fees. That's from the patients. They'd also like to see investment from the government. They did talk about that. They talked about further investment. I think it's the right time to be talking about solutions and broader maybe than what the dialogue's been in the past.
Mm. Well, perhaps we'll finish with that then. Nick, you've touched on what one solution there, which is more transparency and obviously more funding too, but more transparency helping. What other novel ideas from either of you, really, like Lisa or Nick, do we have that might be able to start to address some of the problems that this report is identifying?
Lisa, do you want to go first?
I think you already put the novel ideas out there, Nick.
Oh, look, I've got a lot of sympathy to Les's. If you can see the Q&A, Les has spoken about the Singaporean MediSave and CPF account. Now, let me explain what this is. This is a proportion of income that actually goes into just a medical account that is your own and I think probably your family's. I'm not entirely sure, and you can only spend it on medical costs. So it does address in part this issue of people accessing their super. And I think, whereas I said it's not desirable, no, it's not desirable to access your money, super money for healthcare costs at a system level because it erodes the concept of super. You're supposed to be saving for your retirement. But what if instead of or part of your Medicare levy, so your Medicare levy at the moment is just like tax that goes to the government and you don't even know if it's going to Medicare. Who knows? But if you could imagine some of that you actually retained for yourself. So it's about your own healthcare. Yes, we want to subsidize other people's healthcare, but you've got to look after yourself to look after everyone else first. And that account built up like super over time, and you could access it when you were a young person. So you could pay for things like your out-of-pocket costs to your GP and that sort of thing. The whole thing would be run like a super scheme. It would even be, you'd even have the fund sitting as a little portion of your super fund. But it creates an account that is your own that you can build up over time. Then if that account reaches zero, or someone perhaps might not even have the opportunity to build any balance in the account, then of course you've got Medicare. That is how the Singaporeans do it, and that's how they structure their safety net. They find that it is an interesting one in terms of increased personal responsibility, because and some people don't like that sort of term or concept, and just feel like universal should be for everyone, and this sort of system favours the rich. I think if you have a dual system where you have the Medicare safety net and you can build money through your tax to have this sort of Medicare account of your own to spend, it's an interesting idea. The point is, Dan and Lisa and everybody on the audience, that we are now at the stage, look at the AHI, look at what all the consumer surveys are telling you, look at people talking about collapse of the private system in crisis, great net promoter score, but we are hanging on the edge of a precipice. The point is we need some new ideas, and we need people brave enough to sort of talk about them and shift the dial on how we do things. I think that's just one of many. I've got a bit of sympathy for it, I have to say, but we need to sort of push these ideas out there and get a debate going.
Nick,
There are certainly pros and cons to that. Over to you, Lisa.
what's your technique on some of the hospital models where you have no out-of-pocket costs?
So I really like these. I can this is basically where you have there's about four of them in the country at the moment. They're largely supported through a subsidiary of Medibank Private, as I understand it. And the doctors do get an increased fee from the insurer, and in return, there's an agreement where the patient leaves the hospital with no out-of-pocket costs. So no gap for your hip or your knee or your cataract. I think it's just an example. It's a practical example of what I said with the principle before. There's a movement in both directions. There's a movement down from the practitioners. There's a movement up from the insurers, and it actually meets in the middle, and there's no gap. Now, there's some caveats on that because there's some changes in the model of care, particularly for orthopedic surgery. The reason why the insurers and the hospitals and the doctors can save the money there is that they're moving towards an early discharge model. So instead of staying in for your knee replacement for 4 or 5 days for inpatient physio, people are being discharged at day 1 or day 2 post-operatively. So there's a little bit of nuance there, and it doesn't work for every patient. But I think when you see innovations like that, and like any innovation, there's arguments for and against it. But when you see innovations like that, it's a signal that the problem's big enough that people are looking for creative solutions. So, so yeah, I think we can expect to see more of those no-gap hospitals. I think particularly in a jurisdiction like Canberra, where the out-of-pocket costs are starting to get so prohibitive, we really need to move towards that. At least for some patients, there's going to be some patients and their families who take the view that there is a tendency to say, well, if it costs more, it must be better. I don't necessarily think that's true in medicine, to be honest. Yeah, it's not a view that I share. But there are a bigger group of patients who are struggling at paying several thousand of dollars to be able to walk again, who are privately insured and but are worried about cost and can't wait on the public waiting list. That's the group we need to address here, and that's what no gap hospitals address.
We are fast running out of time, but Lisa, is there anything to add? Any other solutions that perhaps we haven't explored or covered on this one, or is it, or have we've got the main points here?
The last one I throw in the mix is prevention. It's not necessarily innovation, though I think there are lots and lots of innovative solutions that are coming through that will assist with prevention. I think that's a hand-in-hand patients and their providers solution, but prevention in the first place can be a massive cost saving for us as a nation, and then we're reinvesting that elsewhere in the healthcare system, but also it's a massive investment in yourself. So wherever we can do that better, I'm a big advocate.
And what about the tools, Dan? You were saying before the tools for prevention now. That you're the IT guy amongst us. Isn't it great all the things that we've got access to at the moment? So we've spoken a lot about the difficulties in the healthcare system, but actually we're at a time where we've got more information and more potential to engage in prevention than ever before. What do you reckon about AI and the future of healthcare and how it's going to help us live longer lives?
Yeah, I mean, I was going to round out with this, and look, this is a bit of a cliched and perhaps obvious way for me to finish, but I do run a health technology company, so I'm going to speak the benefits of technology, right? So, and I think it touches on a lot of the themes that you both covered. I mean, at a simple level, more transparency is now possible because of the availability of information online, and patients should be taking advantage of that to deal with a lot of the issues that we've been talking about over the last hour. But yeah, as you've touched on there, Nick, and I think you touched on as well, Lisa, the availability of health data now and the ability to use that for preventative means, whether that's with your Apple Watch or your Oura Ring or your Whoop or what have you. I mean, there really is just so many of these different devices that are coming out now that are tracking your sort of daily healthcare statistics. I mean, that has the potential to have real lasting impact on people and getting ahead of their conditions before they become serious. And yeah, look, I mean, AI is being used increasingly in the healthcare system. That's going to have two benefits, I think. One, it's going to do a better job of picking up problems and illnesses before they otherwise would have been picked up. And typically, the earlier a disease or an illness is picked up, the better chance you have of healing it, and the cheaper it is to do so. So that's a big part of it. I also think it has the potential to make care cheaper over time. So if more and more of the more mundane or systematic sort of ways of doing healthcare can be outsourced and automated to a machine and to AI, that's going to free up doctors to do more of the important and complex care that people need. So, yeah, I mean, I think it's not all doom and gloom, right? I think technology really does have an increasing role to play in bringing down healthcare costs, making care more affordable, also making it more accessible. So hopefully we'll see the benefit for that. All right, if there's no further comments, and I'll just remind everyone of the reasons why we're all here, and that is the Australian Healthcare Index 7th report. So you can download the report with a link, which I think has been posted in the chat, at least I'm reliably informed. I hope it has been. If not, if you Google it, you'll be able to find it pretty easily, or you can reach out to us at Health Engine and we'll be happy to send you a copy. But look, thanks, Dr. Nick. Thank you, Lisa, for joining us today to talk about these very important issues. And thanks to all of you as well for joining the webinar. We do this every year. We'll be back again in a year's time to talk about this. And hopefully there'll be a few more positive things to talk about next year. But let's see how we go. Thanks very much for all of you for joining us.